Okay, so we have started the webcast.
I'd like to welcome everybody to our electronic Board of Health meeting. Due to COVID-19 pandemic, regional council is practicing physical distancing and councillors are participating electronically. I'd like to acknowledge that the land on which we gather virtually today is the land of the territory of the Haudenosaunee, Anishinaabe, and Neutral people. We acknowledge the enduring presence of the Indigenous people with whom we share this land today, their achievements, and their contributions to our community. I've now asked Tim Brubaker, meeting clerk, to please do the roll call.
Thank you, Chair Redman. Chair Redman.
Present.
Councillor Armstrong.
Here.
Councillor Clarke. I'm seeing her name, but not her picture, so we'll come back. Councillor Erb.
Here.
Councillor Foxton.
Present.
Councillor Galloway.
Here.
Councillor Harris. Councillor Jaworsky.
Here.
Councillor Jowett.
Here.
Councillor Kiefer.
Here.
Councillor Lawrence. Councillor McGarry. Councillor Nowak.
Here.
Councillor Shantz. Councillor Strickland sent regrets. Councillor Vrbanovic.
President and Madam Chair, just want to advise that I'm going to have to leave shortly after 5:30 to do another commitment.
Thank you very much.
So Chair Redman, we'll go back and check on those who didn't answer. So Councillor Clarke. Councillor Harris. Councillor Lawrence. Councillor McGarry. And Councillor Shantz.
Here.
Okay, so we have a few who, Councillor Clarke is back at her computer now.
That's great. Sorry, I did tell everybody 5 minutes and sliced it a little thin.
So everyone is present except for Councillor Harris, Lawrence, and Strickland.
Thank you very much. Thanks, Tim. I will now entertain a motion to reconvene an open session. This is moved by Councillor Galloway and seconded by Councillor Jowett. I would ask you to use your yes and no buttons to indicate whether you support going reconvening an open session.
That is carried.
Thank you very much. Are there any declarations of pecuniary interest under the Municipal Conflict of Interest Act? Please signify by raising a hand if anyone has any. Seeing none, I would now like to welcome our delegations and remind all delegations of some guidelines for participation in tonight's meeting. Please leave your video and camera turned off and your microphone and audio muted until you're called upon to speak. If you conduct yourself in any of the following manners, it will result in an immediate removal from the meeting, interruption of councillors, staff, or other delegations, derogatory statements about councillors, staff, or others, turning on your camera at inappropriate times, and hate speech or defamatory comments. You will be given 5 minutes to speak. There is a timer and I will provide a 1-minute warning when your 5 minutes is nearing an end. And I will now call on the delegations as listed on the agenda. And the first is Ruth Cameron, Executive Director of ACCKWA, Wilfrid Laurier University. Welcome, Ruth. You have 5 minutes.
Good evening. Thank you very much for having me delegate. My name is Ruth Cameron. I am the Executive Director of ACCKWA. I'm also a member of the Advisory Committee for the African, Caribbean, and Black Network of Waterloo Region. I'm a researcher on the Adinkrahine study, which looks at healthcare access for Black communities within Waterloo Region, and the Outlook study, which was an LGBTQ health needs assessment. I'm also a member of the KW4 Ontario Health Steering Committee and working group focused on refugee and newcomer health. And what I want to do today is to discuss some concerns I have related to some marked, entrenched, and unaddressed disparities with regards to our local COVID-19 response. I'm here to talk about 10 months of sequence of events, which include not responding to data from 2011, 2012, which identified neighborhood health disparities with information that was collected prior to the pandemic, as well as our information that has been gathered during the pandemic, from the start of the pandemic, where we were aware of marked and entrenched health disparities in terms of infection rates, in terms of morbidity and mortality related to racialized and in particular Black communities that were first collected in the UK and the US. And then data that we got here in Canada related to these same disparities and our responses to those disparities. In April of 2020, the ACB network called on the region to mandate the collection of race-based data. And at that time, it was communicated that the region would be following the provincial response and not engaging in the collection of race-based data. Subsequent to that decision, in the summer, when local communities gathered to do a demonstration, what happened was that there were several comments made in media that inadvertently connected the march to not yet apparent predicted surges in COVID-19 transmissions, which never did play out. Subsequent to that, when data was collected that showed that we had, despite only being 2.9% of the population, that Black communities were 10.9% of the COVID cases in Waterloo Region, the remark was made that there wasn't enough data at the time to warrant action. Since that time, in October and November, we now have new data showing that Black people are now 16.7% of the COVID cases in the region, which is a very severe disparity. And in addition to that, we also have information showing that over 60% of cases appear to be in individuals who are racialized as non-white. This is related to the social determinants of health. And I'll remind the Board of Health that the social determinants have nothing to do with race, unlike what is said on the website with the information on health equity. Race is not real. Race is socially constructed, but structural racism creates great health disparities. At this time, when we are now 10 months into the pandemic, I'm concerned that I have only seen responses that involve reallocation of resources to the most disproportionately impacted communities happen after I raised several concerns publicly at the OHT table. Thank you. At the OHT table, at the steering committee table, at the refugee health table, despite several communications with public health related to what was going to be done to address the disparities happening within this community. The isolation program that is federally funded is not, as far as I'm concerned, an example of a health equity response to the Black community. So at this time, I would like to ask how this will be acknowledged and responded to ensure that the burden of morbidity and mortality does not further disproportionately impact the Black community, not only right now, but over generations to come.
Thank you very much, Ruth. Your timing is impeccable. You raise really important issues. I see no questions at this time from Council, but thank you very much for continuing to raise these issues, and we'll certainly take your delegation under advisement. The next delegate is Ncube, Waterloo Republic Health's COVID response. Lang, welcome. You have the floor and you have 5 minutes. You're on mute, Lang.
Thanks. Hey, everyone. Thank you for having me this evening. So my name is Ncube, as stated. And what I would like to talk about today are some of the concerns as well as reservations that I have in regards to the COVID-19 distribution strategy that our region will be working on for the upcoming months. So presently, we are a year into the COVID-19 pandemic, and this past year has extraordinarily exemplified some of the unique challenges that are faced by Black and Indigenous communities within our current health system. So in Waterloo Region, health officials were made aware by community members that, not as you may think, COVID-19 is not an equal opportunity virus. So we know that our healthcare system, as well as our social infrastructures, drive marginalized communities to be disproportionately affected and to be underrepresented and to be ignored in the administration of intervention mechanisms. When data was produced showing the disproportionality of COVID-19 in racialized communities within the region, there was no subsequent strategy to address the specific ways that the virus was being transmitted in these areas. So a system has been created of continued neglect of racialized communities. And as of right now, they don't prioritize our health needs. They don't collect information on how we're impacted. And if the information is collected, if the information is present and the data is there, it's still not utilized. We've entered phase 2 of this pandemic still with no adequate intervention methods from our regional public health. There's a long history of medical distrust in Black and Indigenous communities based on poor practices in medical research, horrific experimentation of Indigenous peoples, and just lack of care in our communities during periods of crisis, which can be seen by the lack of urgency to provide resources to racialized communities that are struggling most with COVID-19 transmissions in the region. So this mistrust will continue to show itself in the rollout of the COVID-19 vaccine. And right now, it's very critical for our public health officials to be cognizant of this as we progress with determining the distribution strategy for the COVID-19 vaccine. There is legitimate fear within our communities founded on the history of medical and scientific racism. Black and Indigenous people have been unlawfully experimented on. Indigenous women, till this day, they continue to be unknowingly sterilized. And racialized people are still often denied treatment and access to medication. So this mistrust that our communities have, it's not misfounded. And this does not mean that this mistrust should be used as a vehicle to ignore us when it's time to distribute the vaccine. There should be ample effort from public health officials to work with our communities on repairing the trust between our healthcare system and us. And this is not something that should be left up to us. It shouldn't, and honestly, it can't be up to our communities to build trust with a public health system that continues to harm and franchise us. So now the question is, what will public health do to rebuild the trust with the public? And what will you do to ensure that the communities which have been ignored for months will finally receive appropriate care? How will you be prioritizing those that have been affected most from this crisis? It's quite evident that a one-size-fits-all approach will not work. There's critical engagement that has to be done by public health with Black communities, with Indigenous communities, and racialized communities, and in particular, engaging with the health experts within those communities. So as history tells, if there is no intentionality with the strategy to distribute this vaccine, we ultimately know which communities will be served first and which communities will be ignored, as we saw with the distribution of the transmission of the vaccine.
Lane, you've got a minute left.
So I'm almost done, and I just want to reiterate this one point as I close off, that it absolutely cannot and should not be left up to our communities to have to build trust with a public health system that continues time and time again to harm us. That responsibility should not be on our communities, and that responsibility needs to be on public health. So as of right now, we are tired of having to save ourselves. Thank you.
Thank you very much, Lang. I don't see any questions from any councillors, but again, thank you for your important intervention, and we will certainly take your thoughts and the comments that you made under advisement. Those are the two delegations that we had registered. We now have a COVID-19 update. Dr. Wong, you have the floor.
Thank you, Chair Redman, councillors. I would like to ask Kathy Prosh to please put up my presentation. Thank you, and she'll move the slides along for me. Thanks, Kathy. So if we go to the next slide. So this is our epi curve. We continue to see new cases slow and move in the right direction, but numbers are still comparatively high to what we have previously seen in the spring and early fall. We continue to manage a high number of active cases and active outbreaks. Our weekly incidence rate is similar to that of the province. We also continue to experience a reduction in numbers. We are currently at approximately 106 cases per 100,000 per week. If we go to the next slide, please. We are currently managing 741 active cases, down from our record high of 1,092 cases. Our previous record from the spring was 348 active cases. Comparing Waterloo Region to other health units, our rates of active cases per 100,000 are comparable to other health units such as York Region and Ottawa. Next slide, please. So I'd like to speak a bit about our analysis of social demographic indicators for COVID-19, as well as what the region has done as part of the collective response to address the systemic inequities. So if I start with this slide, we completed an initial analysis of social demographic indicators for COVID-19 in November. From our initial analysis, the indicators identified that COVID-19 affects more people of color, people living with low income, people living in larger households, people whose first language is not English or French. Our local findings are in line with what has been seen elsewhere in Ontario. The COVID-19 pandemic has accentuated existing structural and systemic inequities. To successfully address the disproportionate effects of COVID-19, we need a greater collective response for groups and neighborhoods disproportionately impacted. For example, data analysis and dissemination by public health, outreach and engagement by regional and community partners, enhanced access to testing through local testing leads, and building connections to primary care through Ontario Health teams. Next slide, please. What the region has done as part of the collective response, we have shared our initial analysis and data with the Community Pandemic Control Group and the Community Supports Group to identify support strategies for those disproportionately affected by COVID-19. Since November, we have applied, been approved for, and have begun operating a 4-room safe voluntary isolation site program. Council funded an interim site with 7 rooms while we submitted our application to the Public Health Agency of Canada. Public Health Agency of Canada has approved a 54-room program with $4.1 million in funding. The program greatly increases our ability to support residents of Waterloo Region who are unable to safely isolate from other household members. Individuals who access the program will also have a sense of comfort knowing that they are not putting their family, loved ones, and other household members at greater risk. We are working closely with health system partners who coordinate and oversee testing in Waterloo Region to identify and deploy additional supports, such as pop-up testing. Workplace outbreaks have significantly increased in the second wave, which has highlighted the importance of adequate paid sick leave. We know from our initial analysis that workers with low income are disproportionately affected by COVID-19. When paid sick time is not available or easy to access, people without paid sick time may be less likely to self-isolate. Regional Council has passed a number of motions to advocate for greater support on these issues, including adequate paid sick leave, more deployment of rapid testing in workplaces, and more workplace enforcement of health and safety measures. I am grateful for the leadership of Regional Council in advocating for more support on these important issues. Next slide, please. Last month, Ontario announced funding for their High Priority Communities strategy. This strategy provides funding to local lead agencies to work in partnership with Ontario Health, their public health unit, their municipality, and other community partners to deliver key interventions. The strategy includes tailored community outreach and engagement to enhance awareness of the services and supports available, including teams of community ambassadors to provide, for example, door-to-door outreach, and developing targeted and culturally appropriate communications. Also, increased access to testing for these communities, such as with expanded or flexible hours. And finally, wraparound supports to connect people with available services, such as groceries and essentials, and emergency financial assistance. Ontario identified 15 neighborhoods in Peel Region, Toronto, York Region, Durham Region, and Ottawa. Hamilton and Windsor were identified as potential expansion areas. Waterloo Region needs to be included. And my last slide, please. Thank you. The strategies identified by Ontario's High Priority Community Strategy are in line with what Waterloo Region needs more support for. We need more support for community-based strategies for targeted neighborhoods, including engaging community leaders and key community groups, expanded access to testing, for example, through pop-up testing and/or testing at community centers, and involving nurses, outreach workers from the communities. Targeted outreach, such as education on personal protection measures, and information on how to access the isolation site. And finally, wraparound services to support individuals who face multiple barriers, such as providing support for groceries and other essentials. So in closing, I'd like to say we need to advocate to the province to have Waterloo Region identified as a high priority community. Thank you very much.
Thank you, Dr. Wong, for the update. I'm going to go right to Councillor Vrbanovic because I know that he's tight for time. Go ahead, Councillor, you have the floor.
Thanks a lot, Chair Redman, and thanks, Dr. Wong, for that presentation and the ongoing work that you and your team are doing. Very, very informative, and certainly I think also clear that pursuing this federally, I believe would federally or provincially would make a whole lot of sense in terms of the nation that you speak of. I guess two questions that I have in terms of our own work right now. Are we making use of things like I think of CKWR community radio, as well as the station at University of Waterloo and so on, to reach out to various communities where there are various ethnic shows on that speak in a variety of languages as ways of communicating with some new Canadians through that, or through some of the other local media that some of them have, whether it's newsletters or newspapers and so on.
Councillor Vrbanovic, I see that Mr. Lochner would like to jump in, so I'm going to go to him next.
Dr. Wong, you okay with me taking that as a start? Thanks. So I think this is an important question, and also, I want to acknowledge the delegation's concerns and comments. They're right. And I think the question to Dr. Wong is, are we? This is where I, as the CEO of the region, I believe need to provide clarity. You all know my history. This region was the creator, if you will, of something called a care community because there was too much of this going on. And we have residents who have been let down by systems, whether that's the healthcare system or the public health system or the education system or the municipal system, you name it. And that had to change. And the care community stopped this and said, let's actually start talking about individuals and let's start talking about things like discriminatory practices. Let's start talking about how these systems harm individuals. And this isn't unique to Waterloo. And so this care community model, now called an Ontario Health Team, was supposed to be anchored in a premise of population health and understanding your population. And every area of the province and the Ontario Health Teams are charged with understanding the population. Who's best to provide that information? Government thinks it's public health. And in my experience, due to a variety of government decisions over the years, some public health units have that information, some don't. The opportunity in Waterloo is it's probably more like public health and universities and the communities themselves and organizations like the organization that Ms. Cameron leads and so on. And that's supposed to be the starting point. And then when we get into COVID, I've said this before, COVID simply shone a light on these issues that were there before and amplified them. And what's supposed to be happening at these tables is let's work together. So back to the specific question, to take tangible action. My view is there's a lot of this going on still in this community. I saw this in health as well, but there's also some good things happening. And I'm glad this conversation is coming forward tonight. To Councillor Vrbanovic's question, are we? I can tell you, I talk to healthcare leaders every day, and they are saying, hang on. We have, and not in every case, but in some cases, we have existing relationships with our patients, with communities, and this isn't a public health thing. This is something that we need to do collectively as a health system. So for example, Lang CHC will say, let us communicate these things. Let us address this. Sanctuary, who works with New Canadians, will say, let us address this. The Inner City Health Alliance will say, let us work this. Our partners, some of our Indigenous-led organizations say, let us speak. It's not appropriate for you to speak. And so that should be the way forward. And whether we're talking about the COVID response, which again, public health is only a small part of, or the vaccine, again, which public health is a small part of or a part of, all these other players have to be part of actioning that. And this is where I know there is confusion and stalling and so on. So I know today our triad leads, Shu Lee, Dr. Ball, Lee Fairclough, I talked to them, need to meet with WOHT as an example, and the Cambridge North Dumfries Ontario Health Team to say, who's doing what here? Because what's happening is our residents are the ones, and let's get going on some of these actions because we need to do better and we can do better. So I hope that gives a bit of a sense of, yes, that needs to happen, but rightly so, we need to respect organizations in health and outside health who have existing relationships and not feel that we need to lead that. That's kind of the old way. That's the colonial way. As an example, our diversity, equity, and human rights team is helping to engage and is part of those conversations. There's conversations that I know some of our delegates tonight are involved in and more. And, that's what needs to continue. and we need to get past some of the stuff where stuff isn't happening, and the colonial system, so to speak, are pointing at each other.
So I guess let me be clear in terms of my question, Mr. Lochner or Dr. Wong. I'm not saying that it's the region that needs to be doing this. It can certainly be partners doing it, but often this has costs associated with it, and partners who have limited budgets
Yes.
don't necessarily have the budgets that they need in order to get this done. And so all I'm asking and all I'm saying is that there are avenues that we can use, and I'm not
Yes.
sure if anybody in the community is using them yet, and they need to be used
Agreed.
as one step towards getting that information out. The second part of my question, Dr. Wong, really has to do with sort of the next step in all of this, and that's the vaccine rollout. And I know, we're doing a lot of great work on this, and kudos to everyone who was involved in achieving yesterday at the 1 year mark, the fact that all of our residents in long-term care have had their first vaccine. My question is, and it really comes out of something that my colleagues on Kitchener Council have raised, has to do with meeting the needs of some of our communities who are most impacted. And while I know that, we're focusing on a number of key locations, as well as pharmacies and physicians and so on, offices for the rollout, I'm wondering what the plans are to potentially meet some of our communities, particularly where we know perhaps incomes are lower, people are working 2 or 3 part-time jobs, and getting to a healthcare clinic between 9 and 5 is just not possible. Do we see ourselves doing any mobile clinics, perhaps elsewhere in the community where these residents live, in order to ensure that they have equitable access to the vaccine?
Councillor Vrbanovic, I know you're directing this to Dr. Wong, and that's great, and I'm sure she's
Sorry?
more than capable of answering it, but after the motion later on in the meeting, we will have an update on the vaccine rollout by Deputy Hilton. So go ahead, Dr. Wong.
Yeah, so I won't just, steal Deputy Hilton's thunder, but I can say that, yeah, definitely, we recognize, and that's part of our plan, that there are going to be populations for which we need to ensure that we just don't provide the normal type of access, but we reach out and try to ensure, working with them, that we're providing the access that they need, right? So that's a big part of our plan. That's actually why we have, as part of the task force, further to CAO Lochner's comments, it's a team effort, right, for the vaccine rollout, multiple players together, and one of the teams is a specific outreach and engagement team, folks like Connie, for example, I know are on the call, could speak more to that, but they have been tasked with making sure that we have these connections, that we work with these communities, so that we can design as best as possible ways to reach them for vaccine access, for vaccine information, and also, we've heard from our Ontario health teams, for instance, they want to be a part, and in fact, the major part of the solution in terms of how this should be rolled out in those communities, because as Mr. Lochner said, they have the oversight over those communities. And so, they are going to have a significant role in helping us design how the rollout will be. So I'll stop there, because I think Deputy Hilton may have more information as part of the vaccine rollout update. But I just wanted to assure you that it is fundamentally a key part of our task force vaccine rollout plan.
Thank you, Dr. Wong. Sorry, Mr. Lochner wants to jump in,
Yeah.
and then I'll
So
go back to you.
just to clarify, they don't have oversight over those communities because, the communities.
Wrong word. Wrong word.
Yeah,
wrong.
yeah, I know what you're trying to say. They have relationships with
Right.
some of the patients, but also the points that were made, by the delegation and others is there's not a lot of trust in systems. And again, going back to health, even where we do have relationships, there's hesitancy sometimes. There is mistrust. I lived in that system where the health system is not always a welcoming space like any system. And that's where discussions need to happen, community-led. And we do know that Dr. Ball and folks like Dr. Jolie at the KW4, Ontario Health Team, some of and others, and nurses and other practitioners are willing to help be part of the solution as communities step forward. I will also say that part of the challenge is we can't change, we can only have so much influence, and we'll continue to try to influence the health system, but even the health system leaders will have some trouble changing the entire health system in the next number of months. But I do believe now is the time, and again, as Dr. Wong says, the OHTs and many partners are willing to say, this is the time. We can't keep waiting. This is the time to start to have those conversations, continue them on, and address some of these longstanding issues. And again, I will continue to be at the table and continue to support those kinds of things. So I hope that helps, Councillor Vrbanovic, answer some of those questions in part.
Certainly very encouraging information, and I would just add that I think each of the municipalities are involved in community and neighborhood outreach through the work that they do at for those of us who have community centers or libraries or other initiatives that have established relationships with some of these communities, and anything that we can do to help to support the efforts, we stand ready to help in that regard. Thank you.
Thank you, Councillor Vrbanovic. Councillor Jaworsky, go ahead. You have the floor.
Thank you, through the chair. Excellent responses by staff on the local situation where the rubber hits the road, and very, very encouraging and very informed now. What I would suggest to perhaps Mr. Lochner is that obviously there's an interest in our community and probably every community out there to let people know, for the province to let people know what their analysis is showing and what other things can be done, because this is something that affects certainly all of Ontario in both COVID-19 and the vaccination. So if we could get that message to the province as well. I don't know if they've done an update on it, perhaps they have, but I think there's certainly strong interest in all communities on hearing more on what the province is doing to analyze this information.
Thank you, Councillor Jaworsky. Councillor Galloway, go ahead.
Thank you, Madam Chair. I'm pretty encouraged by some of the discussion I've just heard from Mr. Lochner and Councillor Vrbanovic, and the integral role of the Ontario health teams as well. And I'm encouraged that some of these other service providers have existing relationships with some of the marginalized communities. I don't know the characteristics of those relationships, but I certainly do hope that those relationships are led by the community themselves, those communities, the marginalized communities themselves. So it's a bottom-up approach as opposed to a top-down approach in terms of the special needs and responses that our marginalized communities need. So I hope that it's informed particularly by those communities themselves. The question I had though was in regards to this high priority funding that certain municipalities got and we didn't. How did that occur? Was that targeted by the province or the feds? The province, I think. And like why was that not, or do we know why that was not made available to all areas of the province, surely there's need, as we've heard today from delegations, and in all areas of the province, not just those that were chosen. Do we have any knowledge of how that happened or how that occurred and what
Dr. Wong?
happened?
What I do know is it just came out one day via press release with the identified communities in Peel, Toronto, etc. And the government has said as part of its release, it was targeting neighborhoods, for example, with very high prevalence rates. Very high percent positivity, that had made the headlines in papers often about some communities in Brampton, for instance, or in parts of the GTA had very significant number of cases. Obviously, they a lot of the time they had the highest rates. Plus, in certain areas and certain neighborhoods, they had very high percent positivity of tests. So they kind of stood out for those reasons. And so, it looked like they were targeting some of the neighborhoods for which there had been some conversation for some time that they were, they were seeing the most significant impacts in Ontario at the time. And they did mention that, they are looking at other places such as Windsor and Hamilton. And that's why we thought, we want you to look at us too. So we'd like to I'm hoping council can do is send a message to the province to say, look at us too. We have similar stats as other places like York and Hamilton. Our rates are similar. We've also done an analysis of those factors like race and low income and household size. We found similar results, and so we believe that we also have a case to receive this funding for those initiatives that with that funding, in partnership with our healthcare and other community partners on the ground who have these pre-existing relationships, we can really accelerate some of the supports that would be available through this funding, if we were to get it. So that's
has there been a call for this, or are we just imposing our will on the province at this point, or is there an application process that's been put out there, or is it we have to now contact our area MPPs and send letters and do whatever we need to do to get the province to include us in this program? And do we know that there is actually a budget left in this program if the government does have a budget for it?
I think Mr. Lochner's happy to jump in, Councillor Galloway.
Yeah, Dr. Wong, did you have any detailed info or? Yeah, so I talked to the deputy about this last week, and as Dr. Wong said, there's a few things going on here. One is the areas of the province that have more prevalence of COVID received more funding. It's very similar to the vaccine rollout, targeting 4 areas ahead of others. We know that some communities just got vaccine this week, for example. So there is some rationale from the provincial perspective. There is a willingness to consider this, but again, this goes back to my comments that a lot of these issues are long-standing systemic issues with this region and others that of how funding rolls out. I know I've spent the better part of a decade with partners in this community lobbying for support for our Indigenous communities, along with colleagues in Toronto. And in urban Indigenous communities don't fall into a framework, if you will, that that the province for eons and eons finds convenient for funding strategies. So short version is they get left out a lot. And a lot of this, Councillor Galloway, is historical viewpoints and lack of understanding. So again, not new issues, but real, very real issues that continue to impact people in this community because of the inequities. So we are pushing with the deputies and the ministries to say we need this funding.
So could I ask then, Mr. Lochner, I mean, do we have to wait for the funding to come to do the right thing here? Can we not proceed to do what we need to do and then, so to speak, bill the province later as we're incurring costs, all different types of costs associated with COVID, which the province is
working with our partners in health. We have done that, and we need to continue to do more of that because the health partners have the same thing, and collectively we've decided with the hospitals and primary care providers, OHTs, and so on, as we did during COVID, to just go ahead and build a province. And if we don't get funded for that, then so be it. We'll have to figure that out down the road.
Well, it seems to me, I mean, while our positivity rate may be lower, and thankfully it is, than some other areas that obviously need more resources, doesn't mean that we don't need any resources.
Right.
And I know the province has been very good to us in general, but when it comes to this particular program, it seems to have been selected. I wouldn't expect that we would get anything to the same extent that Peel would with its rate and its demographics, but we should certainly be eligible for some share of the budget for this particular program. But on the other hand, I'm not suggesting we wait for that. I'm thinking we've got to move more quickly and deal with the financial aspect later.
Well, and I think, Councillor Galloway, we have a really good example of that. Staff have not been sitting on their hands. I know Councillor McGarry's ready to jump in with her.
No, I realize that. I'm not.
But, if you look at the voluntary isolation rooms that we set up, and that was really the genesis of that was a question Councillor Clarke posed a few weeks ago. We took it on. We had we're footing the bill for 7 rooms. We now have 4.1 million from the federal government. So I think this is a similar initiative. We're not waiting for the province, but we do want to stand up and say we'd like our share. Councillor McGarry, go ahead.
Thank you, Chair, and through you, be an appropriate time to place a motion on the floor precisely about what we're talking about, with your leave.
Go right ahead.
Yep, thank you. It's moved by myself, seconded by Councillor Clarke, and the motion's titled Advocacy to Designate Waterloo Region as a High Priority Community. Whereas the Government of Ontario is providing additional pandemic supports to marginalized communities across the province designated or designed as high priority communities. And whereas in November 2020, Region of Waterloo Public Health released data demonstrating the disproportionate impacts of COVID-19 on Black and racialized community members and those living with low income. And whereas in November 2020, Regional Council approved funding for voluntary safe isolation spaces, and Public Health has launched an isolation centre with $4 million worth of support from the Government of Canada through the Public Health Agency of Canada to provide a safe place for community members to isolate and prevent the spread of COVID-19. And whereas the Region of Waterloo Public Health continues to work closely with the health system partners to identify and deploy additional supports to marginalized communities, including mobile testing. Being designated a high priority community would provide much needed provincial resources to expedite deployment of supports, as has been done in other communities across Ontario. Therefore, be it resolved that the Board of Public Health direct the head of council to urgently advocate to the provincial government that Waterloo Region be designated a high priority community to deal with the increasing demands of the COVID-19 pandemic on our marginalized communities. And further, that this be shared with local municipal councils, local MPPs, and MPs. Thank you.
Thank you, Councillor McGarry. If you have no further comments, I will look to Councillor Clarke. Would you like to make some comments as the seconder of this motion?
Actually, I think all the comments that need to be made have been made, not just in Councillor McGarry's resolution, but in all of the comments.
Thank you very much. I see no further comments. Are we ready for the question? McGarry, thank you for reading the motion. It's moved by Councillor McGarry and seconded by Councillor Clarke. We've all just heard the motion. So I'd ask you to use your icons to vote yay or nay.
That's carried unanimously.
Thank you very much, Mr. Brubaker. That is carried unanimously. And again, thank you, Councillors McGarry and Clarke, and all of Council for supporting this important motion as we go forward. And just further to Councillor Galloway's comments, we will continue to work on these issues and focusing on the marginalized people in our community who have been disproportionately affected by COVID. And I take your point that it's great to lobby senior levels of government, but we won't sit around waiting. Next, the agenda item is a presentation by Deputy Chief Hilton on the vaccine rollout. Welcome, Deputy Hilton. You have the floor.
Good evening. Thank you, Chair Redman. Just further to last week's update, as a result of the Pfizer supply issue, the Grand River Clinic for vaccines was closed last week, so that all efforts in vaccine could be focused on the mobile teams for long-term care homes and the high-risk retirement homes. So as of the end of last week, as already mentioned, this has been accomplished. So this target was met at the end of last week. However, with the announcement yesterday with the further delay in vaccine from Pfizer, we know that the province of Ontario has not been provided their allocation as of yet for February 8th and February 15th, those 2 weeks. And I believe we have a very limited supply coming to Waterloo Region next week. The second dose, all vaccine for Waterloo Region will be to the long-term care homes and high-risk retirement homes to ensure that second doses are administered between days 21 and 27. And all other groups are being pushed to no later or up to 42 days for their second dose. So that includes our healthcare workers and the healthcare workers in the hospitals, but also within the long-term care home and retirement homes. And this is a strategy from Ontario we are following, from the province that we are also following until we have an idea of further allocation of the Pfizer vaccine. Again, reiterating that we have not received the Moderna vaccine. We are only dealing with the Pfizer vaccine in Waterloo Region. And until we understand supply and the stability of supply, that is the direction that we are moving. No vaccines will be for first vaccines. It's all dedicated to second dose for the long-term care homes and high-risk retirement homes. I know there was a conversation occurring around community outreach, and I will confirm that as part of the vaccine rollout, a community engagement and outreach working group was established. And they were established to ensure that a strategy for meaningful community engagement to support smooth and rapid vaccine to all residents of Waterloo Region in a safe and equitable manner. But this also includes building trust and confidence in the vaccine itself around the safety, also on implementation of the vaccine distribution in ways that will meet the needs and then hopefully assist in overcoming some barriers faced by priority populations. To date, the vaccine working group, the community outreach working group, they are coordinating with the existing health system tables, as well as conducting outreach with leaders within organizations and communities serving various priority populations to help assist with the vaccine rollout. They are engaging with the Ontario Health Team tables and service providers to ensure that the vaccine distribution plan reflects and best meets the needs of at-risk in the marginalized community, and understanding what is the best method for some of our populations, which was already discussed here earlier around the mobile teams. What is the best way to reach some of our priority population? They're also reaching out and engaging with community leaders, including faith leaders, to develop a communication plan, again, to try to build trust in the vaccine and confidence in the vaccine itself. Direct engagement sessions with the faith leaders and other groups to identify further communication needs and outreach opportunities. And then looking at creating culturally appropriate communication items related to vaccine confidence and safety, so that can be disseminated throughout a lot of the different the channels to each community and priority population. And what was already said earlier, it is looking at and leveraging already existing relationships to be able to serve the community in the need in the way that is appropriate. Thank you.
Thank you, Deputy. Councillor Clarke, go ahead.
Thank you for the presentation. I've been following the rollout, the plans for the rollout very closely, and as I understand it, the priority for phase 1 was residents and staff working in long-term care facilities in Indigenous communities. Phase 2 extends it to staff and residents in other kinds of congregate care facilities, as well as individuals over the age, I think, of 70. And then there's a more general population. What I can't quite hear from what you're saying is whether there's any latitude, I know these are provincial, whether there's any latitude locally to identify priority populations within those priority populations. Such as one of the delegations talked about whether we have the ability, for instance, to say we are going to accelerate vaccinations to this demographic group. I don't see in the provincial regulations where that's an option, but maybe I'm wrong.
Deputy Hilton or Dr. Wong, who would like to take that?
I will defer that to Dr. Wong.
Yeah, so it's pretty prescribed in terms of, you know, the groups and where they've been placed in the rollout. So for example, you know, there is a recognition that certain communities are disproportionately affected. The government has actually used an example of Black and I believe it's racialized, and they have mentioned groups like that as part of phase 2. And so they have identified certain groups, like you mentioned, Councillor Clarke, that would be in phase 1, like long-term care, home residents, staff, at certain high-risk acute care, health care workers, and then as we get more vaccine, you know, the other groups in phase 1, such as the urban Indigenous, and there is another group of chronic home care patients. So these would be part of phase 1, and then there's other groups as part of phase 2. And they have been to date quite directive because of the very small supply. So, you know, they know how many homes we have, they know how many residents we have, they know how many, well, approximately at least, and we're given supply for that. So if you know, we need to hit those priorities with the supply that we've been given, and we wouldn't be able to, just decide to take that and minimize another group, for instance. It needs to be that group. So it's been pretty directive to date. That's because of the supply issues. I anticipate that as supply gets better and better, which is anticipated to do, but more on an exponential level as opposed to a linear level, because right now it's very limited, right? Then it will be less and less of an issue because we'll be able to immunize multiple groups concurrently.
So conceivably, once we get to phase 3 and we're into the general population, we would be able, we would have the latitude locally to say we're going to go first to low income neighborhoods, for instance.
Bruce has something to say.
Yeah, so
Go ahead, Bruce.
into my point that this isn't being driven by public health.
I understand. That's why I'm asking.
And so if the analogy I often give is the flu shot. So we roll out flu vaccines every year. We actually don't roll it out. The government gives it to physicians' offices and nurse practitioner offices and pharmacies. That's a very similar strategy, Deputy Hilton and Dr. Wong, as I understand it, to this. Very dictated. And so as much as we would like to respond to concerns, including examples of those raised tonight and others, like you're raising low income, that's not a local decision because it will go through predominantly through the existing distribution channel. But if we were given that opportunity, which we haven't yet, we would definitely take advantage of that, where Dr. Wong's expertise would weigh in on, we believe this group should be done before that. And that's part of the anxiety might be one word, but part of the concern that's raised. And I think some of the confusion that there's a sense that we are determining who goes next. No, it's provincially dictated. And that's where we can advocate to highlight information that you're putting forward, information we heard tonight, to the province to say, please change this, because wave 3 will be too late for some of these considerations.
Councillor Clarke, any more questions?
No, that answers it. Thank you.
They would be.
Go ahead, Dr. Wong.
Sorry, they would be in phase 2. They would not be in phase 3. The more disproportionately affected populations would be in.
And again, I guess the other thing worth noting is that it says phase 1, phase 2, and phase 3, but they flow, and there's not a hard stop and start. So we're not getting hand signals when we're done phase 1 and into phase 2. They kind of blend.
Exactly. You got it.
Councillor McGarry, go ahead.
Thank you. And it's really a follow-up question through to Councillor Clarke's and through you, Madam Chair. I know that we've talked about congregate living settings. I know that the staff and some of the residents at our local shelters are at also one of those high-risk categories. So just wondering when those staff members and residents of that congregate care setting may be considered. Is it in phase 2?
It's in phase 2. Of course, if we have vaccine earlier, we can move up the timelines. It's just right now there's still a lot left in phase 1 that we have to do, like all the other congregate care seniors that are not long-term care and high-risk retirement homes or homes designated by the Retirement Homes Regulatory Authority. There's other seniors congregate care. There's the home care. So there's a lot to catch up with once the supply improves. But like Chair Redman said, it's fluid. And if we get more supply, because Pfizer's supposed to give us a bit more supply, since they're giving us less now, we'll see if we'll be able to move anyone up a little bit, but we'll have to see.
And I really hope it's not lost on anyone when Dr. Wong was saying that it's not an increase like this, but an exponential one. So that one of the things that Deputy Hilton and our entire vaccine task force rollout team is looking at is not only the fluidity of when phase 1 morphs into phase 2 or phase 3, which is prescribed by the province, but also being flexible enough to adapt to a trickle of vaccines and then a whack of vaccines, and still always having the priority of getting the vaccine in arms. And I think our team's done an amazing job. I see no further questions. Thank you all so very much. And again, Deputy Hilton and Dr. Wong, thank you for everything you do on behalf of our community. And I know that there's a huge team of people behind you, so please extend our thanks to them as well. See no further questions. I'll now entertain a motion to enact the bylaws first, second, and third readings. This is moved by Councillor Galloway and seconded by Councillor Armstrong, that a bylaw be passed to confirm the actions of the Board of Health on January 26, 2021. I would ask you please to use your icons and vote in favor or against.
That's carried.
Thank you very much, Mr. Brubaker. I will now entertain a motion to adjourn this meeting. This is moved by Councillor Foxton and seconded by Councillor Kiefer and undoubtedly cheered in all sectors. So again, would you use our icons to vote yes or no?
And that's carried as well.
Thank you, colleagues, for a very informative, important meeting. And if the delegations, and I think a couple of them are still on, thank you for adding your voices to this very important discussion. And everybody stay well and good luck for those of you that are trying to make another meeting.